Good day, everybody. This is On Call with Doc Dave, episode 6, a very significant episode, and with potential life-threatening symptoms and presentation as well as pathology. So today's episode is going to be on chest pain, and we're going to break it down into either non-cardiac or cardiac chest pain, because there can be two different types. Now, chest pain generally is in males, usually greater than 60 or 70 years of age, although it's getting more common in females. Precipitating factors for chest pain usually are sex, age, obesity, history of hypertension, high cholesterol, type 1 diabetes, which is insulin dependent, smoking, stress, some family history is very important, sedentary lifestyle, and congestive heart failure. Now, if you got any of those complications or pathology in your system, then this is a very important and significant episode for you to pay attention to, or any of your family members, loved ones, or friends. Now, the symptoms of chest pain. First of all, we got the non-cardiac atypical chest pain. This is not a medical emergency. This can happen to anybody in their 20s, 30s, 40s, 50s, and so on. The most common cause of this is something that we call in medicine costochondritis, which is a chest wall muscle inflammation. And it can come on from, doing over heavy lifting, maybe a minor trauma, doing push-ups, working out at the gym, anything where you're going to strain the muscles in your chest wall right along your sternum where your ribs hook in. There's a little ligaments there. And if those ligaments get stressed or strained, it's going to feel like a heart problem, but it's not really. And usually the symptoms that you can differentiate that from actual chest coronary disease is that it comes on relatively abruptly. It's sharp in nature. It's not heavy and squeezing like cardiac chest pain. It can be reproduced. If you put your hand or your palm over your ribs and you push down, you'll feel a reproduction of the similar chest pain that you were having symptoms with. So it's easily diagnostic by, the onset, the history of either overstressing the area or reproduction of the pain. So if you have that type of disorder, it's very easy to treat. You got to rest. Whatever you were doing that precipitated it, you got to avoid that for a few days or a week. Take over-the-counter non-steroidals, Advil, Aleve, Motrin, ibuprofen. Put a little heat on it so it promotes the blood flow and the healing process. And just, as long as you don't have any other significant risk factors that you want to have this checked out with, then it'll resolve itself and you won't generally have any further symptoms unless you reoccur the disorder by the same pathology that you did to get the initial disorder. So that's atypical chest pain, muscle wall, non-cardiac, nothing to be concerned about. Now, the ones you need to be concerned about, it's called angina. And there's different types of angina. And this needs immediate medical attention. Your doctor obviously should be aware of this. This could be something you can discuss with him over the phone initially and then see him in his office on an urgent basis, or you go to the emergency room and get checked out immediately. So angina, the different types of angina. You got stable angina, which occurs during physical exertion and relieved by rest or nitroglycerin. So this is, you're just resting, you get up to go for a walk, or you're doing some heavy activity, and that stress on your coronary arteries will precipitate the chest pain. When you go back and rest again, or you take a nitro and it goes away, then that's what we call stable angina. Now, there is obviously unstable angina, and this is a medical emergency. This occurs at rest or with minimal exertion. So if you're just sitting there reading a book, watching TV, you're not doing anything stressful, and all of a sudden you get this pressure in your chest, and regardless whether it goes away with nitro or not, this is something you need to have urgent medical attention for. So generally you would go to the ER, get your EKGs, get worked up, and we'll go over this in more detail. But the unstable angina is a real red flag and something that you really shouldn't be ignoring. Now, there's also something called accelerated angina, which comes on with more frequent episodes of angina. So in other words, if you had a little chest pain, once a week, once a month, kind of goes away with rest, maybe you take a nitro or two and it goes away, and then it doesn't come on again. But in this case, with accelerated angina, you're getting it more frequently. So instead of once a week or once a month, you're getting it maybe 2-3 times a week, or 4 or 5 times a month. And even though it might resolve with rest and nitroglycerin, if it's accelerating and coming on more frequently, then this is something that you need to get evaluated and get checked out by your doctor or cardiologist specifically, or go to the emergency room and have them make sure that you didn't have a myocardial infarction associated with this. Now, the last one is something called Prinzmehl, or variant angina. And this is secondary to coronary spasm. So in other words, your coronary artery just goes into a spasm for some reason. It's not really known what the precipitating factors of this is, but instead of having actual pathology in your coronary arteries, like blockage or hardening or clots in your coronary artery that can cause a myocardial infarction, this is actually, you could have a normal coronary artery and it just goes into spasm and it produces the same symptomatology that pathologic coronary arteries do. And it will respond to rest, it will respond to nitroglycerin, and so you may not have had a history of this first time onset. Obviously, you got to get a thorough evaluation, but your doctor eventually or the cardiologist will figure out that it was due to coronary spasm rather than, coronary disease. So those are the different types of angina that you can have, and they're all, something that you need to be aware of. You need to have a physician monitoring this. You need to have a specialist, a cardiologist. You need to go through different testing, like stress test or treadmills or echocardiograms or even a cardiac catheterization to make the correct diagnosis. The type of chest pain this angina comes on with is different than the costochondritis, the muscle chest pain, which was sharp and reproducible. This type of chest pain is pretty consistently, it's a very heavy squeezing. Patients say, it feels like an elephant was sitting on my chest, and the pain got very heavy. I got a little shortness of breath from it. I was having some trouble breathing. I broke out in a cold sweat, which is called diaphoresis. I got nauseated. I might have had some palpitations and lightheadedness. And it radiates to my neck or into my left upper extremity, and then down the left upper extremity into the hand. That is the classic presentation of angina coronary artery disease. And that's the type of thing that you need to seek urgent, immediate, emergent medical attention. You take your nitroglycerin, which you generally probably already have. The way you take it, I'll describe later, but it's generally you take one, you wait a minute, you take another, you wait a minute, you take a third, and if the pain doesn't completely clear up by the third, then you got to go in emergency and get looked at urgently. Now, what is the pathophysiology of angina, the coronary artery disease? The coronary artery disease are narrowed, with atherosclerosis, which is hardening of the artery, and they have friable clots. And this is the thing that actually causes the heart attack. So in other words, you got a narrowed coronary artery, you've got some hardening of the artery, you got cholesterol deposits in the artery, and these are eventually they break off for one reason or another, and they go downstream and they block the coronary artery, and then that part of the heart that is supplied by that particular coronary artery will be affected. You would get a myocardial infarction, and that muscle part of the heart will die. And that's how a heart attack presents itself. You can have either a right-sided heart attack, which is a right coronary artery, or a left-sided heart attack, which is a left coronary artery. The right-sided heart attack affects the right ventricle, which is one of the main pumping vessels of ventricular into the lungs. And the left side causes injury, damage, or death to the myocardial muscle, and therefore causes, to have congestive heart failure, backage up of fluid into the lungs, and so forth. Now, there is a specific coronary artery, the left anterior descending, or what we call the LAD, and it's called the widowmaker, because if that is affected, it blocks the entire left side of the heart, not just a segment of the myocardium, but the entire left side of the heart. And generally, you cannot survive that type of a heart attack. And that can only be diagnosed by doing a coronary angiogram, where they insert a needle into your vein, usually in your groin, and they trace the catheter up to your into your inferior vena cava, into your heart, and they into not the inferior vena cava, but the artery, into your heart, and then they inject the dye, and they will see that left anterior descending, and that is a cardiac emergency. They will immediately put a balloon in that and inflate it to decompress that obstruction. So that's something that's very important and you need to know as well. Now, how do you diagnose this? Okay, so you get the chest pain at home, you call your doctor, you go to the emergency room. What do they do when you get into the emergency room to evaluate and determine whether this is a heart attack, whether it's just angina, or maybe even something else? But so it's pretty standard and pretty straightforward. You'll get into the room. They immediately will put, a monitor on you, cardiac monitor, to look at your rhythm. They'll put oxygen on you to give increased supply of oxygen into your system. They'll have an IV started on you so they can have access if they need that. They'll do an immediate EKG. They'll look for any arrhythmia, which they may see on the monitor as well, or look for any signs of heart attack ischemia or an actual myocardial infarction. And those are determined by, whether ST waves are going up, going down, or whatever. But we won't get into that because that's too much detail. But the EKG will be performed. They will do a chest x-ray to make sure that there's no other pathology, like maybe a collapsed lung or a blood clot or pneumonia or something, congestive heart failure in the lungs that could be precipitating this disorder or even simulating the disorder. They will do blood test, and the main blood test they will do is something called a troponin, and that troponin is determined in your blood from the damage or death to certain part of your myocardium, which is the muscle in your heart. Like I said earlier, once that little clot breaks off and it goes distal and it obstructs the blood flow to a certain and part of the anatomy of your heart, that part will die off, and it will release an enzyme into the system called the troponin. And the troponin is very sensitive, and if your troponin's elevated, it means you probably have had some type of a heart injury or a full heart attack. And the only way they can differentiate that is do a cardiac catheterization as well. So you get that blood test done. Now, the troponin is interesting. in that it usually takes about 4 hours for the troponin to show up in your blood test, even from the original injury. So in other words, if you go into the emergency room immediately and you're there within 45 minutes of the onset of the chest pain, and they draw the blood test, and even though you may have had a heart attack, and they could probably pick that up on the EKG in itself, but even if the EKG is normal and the troponin's normal, they'll generally keep you in the emergency room for another 4 hours and then repeat the troponin, because the original could be a false negative, meaning it hasn't elevated yet, and then 4 hours later they draw it again, and what do you know? It's elevated, and they take you off to the cath lab. So you don't just get one negative troponin if it's been under 4 hours since you've gotten there, had the disorder. They'll get a repeat one at 4 hours or maybe 5 hours. And if you've had the chest pain for 8 hours before you get there and the troponin is normal, then that's generally a good sign. But if you have it, if you've had the heart attack and you get there 8 hours later, you can guarantee it's going to be elevated. So how do they treat this at that point? Well, they give you nitroglycerin, they give you a baby aspirin. Now, if you haven't had a baby aspirin, generally people take baby aspirin every day if they have a history of heart disease. But if you didn't have it that morning, or maybe it's your first time, they'll give you a baby aspirin, a 61 milligram aspirin, unless the EKG shows that you've had a heart attack. Then they'll give you a 325 milligram aspirin. Then they'll give you the nitroglycerin, they'll give it to you under your tongue. And, because what the nitroglycerin does, it's a smooth muscle relaxant. It relaxes the coronary arteries, opens them up, lets the blood flow better, and therefore the chest pain will start to resolve. And usually it'll give you a maximum of 3 of them. They space them 1 minute apart. And if after the third one it doesn't help, then they give you what's called IV morphine, which is a preload reduction, so it decreases the stress and work of the heart, plus it's an analgesic, a narcotic, so it'll relieve the pain as well. So that's kind of how it's going to work when you're in the ER. And like I say, if things go bad, or if it shows you've had a heart attack, they'll take you right into the cath lab, and they'll do a cardiac catheterization on you. And if they see the obstruction, they got that balloon that they'll put in there, and it will open up with like putting a stent in there. It'll open up the artery and let it flow in. Now, if you're in a smaller hospital that doesn't have a cardiac cath lab or a cardiologist on scene, and trust me, there are a number of hospitals like that, even in California, then if they diagnose that you've had the heart attack, but they can't take you to the cath lab to put the stent in yet, they'll give you some medication which is called TPA, and it's basically a clot buster. It will go in and bust up that clot and clear the clot out. And it's a thrombolytic, which means it'll dissolve the clot and buy you some time so that you can get from your hospital to a major facility that has a cath lab and a cardiologist on scene. So how do you prevent, heart disease, angina, this and that? You can only prevent it so much, but prevention is very helpful, and it can prolong the disorder so that you can, have a more productive lifestyle. Main things are, if you're obese, you got to lose weight. You got to get your body functioning well and not overstressed with, a sedentary lifestyle precipitating obesity. You can control your risk factors, which are your blood pressures, by taking blood pressure medicine, diabetes by taking your insulin, cholesterol by taking your anti-cholesterol medications, and congestive heart failure by taking your heart medication and your diuretics that you need to be on. The other thing is to stop smoking. Even if you think, well, I've been smoking for 40 years, just stop. Because that will give you a better chance to, prolong any onset of a heart attack and get worked up and maybe get, proactive stents and things like that so that you don't actually have a heart attack. Regular exercise is good. Don't overdo it, but exercise, walking's good, swimming's good. Decrease stressors as much as you can in your life, and get regular checkups by your physician. So this was a rather complicated episode, but it was very important, and hopefully had a lot of good information in there for you. You may want to listen to it again because there was a lot of information that you have to digest here. So a second run through this may be good for you, or if you have a family member that has been having angina and stuff, this is good for them to listen to as well. So thank you for your time again, and I'll be seeing you soon with another informative episode. And remember, I am your friend, not your doctor. And thank you for your time.